Okay, let's unpack this. Imagine a medical emergency. It's rare, maybe a bit hidden, and it absolutely demands lightning speed to prevent, well, a lifetime of consequences.
Yeah, the serious stuff.
That's the territory we're exploring today. We're doing a deep dive into Cauda Equina syndrome, working directly from these really detailed revision notes that you've shared with us.
But what's truly fascinating, and frankly pretty critical, is how this condition, even though it's not that common, carries such incredibly high stakes.
Yeah.
Permanent damage is a very real risk if it's not spotted and treated fast.
Definitely.
So our mission in this deep dive really is to boil these notes down into the absolute essentials, make the critical information high yield, easy for you to recall, especially, when you're under pressure in a clinical setting.
Absolutely. We'll navigate right through the material you've given us, breaking down each key area. So let's start right at the beginning, shall we?
Sounds good.
So at its core, what is Cauda Equina syndrome? Looking at the definition you've laid out here, it's described as, well, rare, but a really serious neurological condition.
The fundamental problem is compression, essentially. Something is squeezing the nerve roots that make up the cauda equina right down at the bottom of the spinal cord.
Exactly.
And the impact of that squeeze, well, it leads to pretty significant symptoms, the potential for severe complications, and critically, it requires immediate medical attention. That often means urgent surgery.
Right. And to build on that, think about where this is all happening. The Cauda Equina, it literally translates to horse's tail, which is actually a great visual.
It really is.
It's that bundle of nerves continuing down the spinal canal after the spinal cord itself typically ends, usually around the L1 or L2 level.
Okay.
So when these specific nerves get compressed, it just disrupts their ability to send and receive signals, to and from the lower body.
Right, that communication pathway. Exactly. And this disruption is what causes that cluster of severe neurological deficits, including, and this is absolutely key, problems with bladder and bowel control, and also sexual function. Your notes really emphasize this. Urgent treatment is necessary. And remarkably, it's often based only on clinical suspicion when you first encounter it.
Wow. Okay.
You just can't afford to wait for every single test result before acting in a suspected case.
Hmm.
Recognizing those signs quickly is paramount, both for your revision and obviously for patient outcomes.
Right. That sense of urgency really comes through in all the information here. So if it's compression of those nerves, what's actually doing the squeezing? This is where your material gets really interesting, outlining quite a few potential culprits.
Yeah, there's a list.
The most frequent cause highlighted is a significant herniated disc, particularly down at those lower lumbar levels like L4, L5, or L5S1, pressing directly onto those nerve roots.
That's the classic one.
But that's just the start, isn't it?
Yeah.
We also see common causes listed like tumors, maybe metastases spreading to the spine, or lymphomas growing in the area. Then there's trauma to the spine, infections like an epidural abscess forming near the nerves, and even congenital issues you might be born with, like severe spinal stenosis or kyphoscoliosis or spina bifida.
And the source material actually goes on to list some less common but still really vital causes you need to keep in your mental checklist, when you're thinking through the possibilities.
Okay, like what?
Things like spondylolisthesis, that's where one vertebra slips over another, or conditions causing inflammation in the spine, like ankylosing spondylitis, or even a hematoma forming after spinal surgery.
Right, complications.
Yeah. And they even point to less obvious things like complications from spinal manipulation or inferior vena cava thrombosis, or even systemic inflammatory conditions like sarcoidosis.
It's quite a diverse list then.
It really is, isn't it? It just shows that pretty much anything impacting that specific space around the cauda equina can potentially cause this syndrome.
So given that range of causes, are certain people more likely to get this? Your notes lay out the risk factors pretty clearly.
They do?
They indicate that individuals with pre-existing spinal conditions, like those herniated discs or the spinal stenosis we just mentioned, they're at higher risk.
Makes sense.
A history of previous spinal tumors or infections also increases vulnerability. Any significant trauma or injury involving the spine is a clear factor, as are previous surgeries on the spine.
Yep.
And then there's age. Apparently middle-aged and older individuals are more commonly affected.
And the reason behind these risk factors is, well, pretty straightforward, really. They all either directly involve or significantly affect the spine and the structures immediately surrounding the cauda equina.
So it just makes that compression more likely.
Exactly. It makes that critical nerve compression more probable.
Ah.
So recognizing these factors in a patient who presents with, concerning symptoms should absolutely heighten your suspicion for CES.
Okay, let's talk about the nuts and bolts then, of how this all translates into symptoms. The pathophysiology. The material explains it quite simply, actually.
Yeah, the mechanism itself isn't too complex.
It says the compression of those nerves physically disrupts or blocks the transmission of signals, those electrical messages between the lower extremities and the brain, and obviously vice versa.
It's like cutting off a vital communication cable, basically.
Yeah, good analogy. And the result of that disrupted signal transmission, it directly causes the symptoms we associate with CES, the motor weakness, the sensory loss, and that really critical dysfunction of the bowel, bladder, and sexual function.
And what's crucial here, and this point is really strongly emphasized in the notes, is that the severity of the symptoms and the degree of functional loss depend heavily on how much compression there is, and perhaps more importantly, how long it lasts.
Ah, the time factor again.
Yes, if this nerve damage persists because treatment is delayed, it can become permanent, and that leads to lasting functional impairment. This is precisely why your source material underlines the absolute necessity of timely intervention. You are literally racing against the clock to preserve nerve function that could be lost forever.
Wow. That stark reality makes the next section incredibly important for anyone, needing to assess a patient. The differential diagnosis?
Right. What else could it be?
Exactly. If someone presents with back pain and some neurological issues, what else could be going on that might look similar but isn't CES? Your notes provide a list of conditions you absolutely need to consider and differentiate from.
Mm-hmm.
This includes maybe simpler things like a typical lumbar disc herniation causing a radiculopathy, nerve pain down the leg, or general lumbar spinal stenosis, or maybe other causes of acute back pain or sciatica.
Sure, the more common stuff.
But it also includes more serious conditions like other spinal tumors or infections that might be located higher up or present a bit differently.
And a key point from your material regarding differentials is specifically mentioning coda medullaris syndrome.
Ah, okay. How's it different?
Well, this affects the very end of the spinal cord itself, the codamus, not just the nerve roots below it in the cauda equina, and it often presents with a slightly different symptom profile. It's primarily characterized by more profound and abrupt urinary retention and constipation, where CES can sometimes have a broader range of bladder or bowel issues that might develop a bit more gradually.
Got it.
Other conditions listed to keep in mind include simple mechanical back pain or prolapsed disc without significant compression, maybe a fracture, broader spinal cord compression higher up the spine, or even something like a generalized peripheral neuropathy affecting many nerves, not just those specific ones at the cauda equina level.
Okay.
This list really highlights the challenge, doesn't it? Distinguishing CES from these conditions quickly.
Which brings us to perhaps the most high-yield part for practical application, the clinical features.
Mhm.
These are the red flags, right? The signs and symptoms you need to recognize immediately to even suspect CES and trigger that urgent workup.
Absolutely critical section.
Your material lists the classic symptoms. Severe low back pain, pain radiating down one or often both legs, motor weakness or even outright paralysis in the lower extremities, and sensory loss or numbness affecting the buttocks, groin, and legs. But pay particular attention to the really vital signs. Loss of bowel or bladder control, that means incontinence or maybe difficulty emptying sexual dysfunction, and altered or absent reflexes in the lower extremities.
Exactly. And while those symptoms are crucial, the characteristic examination findings are your ultimate guide, according to these notes. The absolute standout, the one you really need to look for, is saddle anesthesia.
Okay, define that simply.
It means loss of sensation, specifically in the perineum, the perianal area, and potentially parts of the inner thighs, essentially, the area that would make contact with a saddle if you were riding a horse.
Right, clear visual.
You also need to look for reduced power in the lower limbs, absent ankle reflexes, which can sometimes be asymmetrical, by the way, and specific signs of bladder or bowel dysfunction on examination, things like difficulty initiating urination, overflow incontinence where the bladder is just so full it leaks, or fecal incontinence, or maybe severe constipation. Sexual dysfunction is also a key feature to ask about, though sometimes patients might be hesitant. And your material includes a really important warning. Even if the leg symptoms seem partial or affect both legs rather than just one, this could still indicate partial or impending CES. So you need to maintain a high index of suspicion.
Gotcha.
This entire section, honestly, is the must-know list for identifying CES clinically. If you see these signs, act fast.
Okay, so you've got a patient with those red flags, you've done your exam, and you strongly suspect CES. What's the next step to actually confirm it?
Right, the investigations.
Your source material clearly states that the gold standard investigation is an emergency MRI of the spine.
Yep, that's the key test.
And if MRI isn't immediately accessible or maybe contraindicated for some reason, a CT scan is mentioned as an alternative, though MRI usually provides better detail of the soft tissues and nerves.
Exactly. The whole point of the MRI or CT is direct visualization. It allows you to actually see the compressed nerves, confirm the diagnosis is indeed CES, and importantly, identify what is causing the compression. Is it that disc, a tumor, an abscess?
Find the culprit.
Precisely. Your notes also list other investigations and explain their role. Things like EMG or nerve conduction studies might be used later on, perhaps to assess the extent of nerve damage or tract recovery, but they're not for the acute diagnosis.
Okay, not for the emergency room.
No. A lumbar puncture or maybe blood cultures are crucial if you suspect an infection is the cause, particularly in patients who might be immunocompromised. General blood tests can help rule out other systemic conditions.
Makes sense.
And a bedside bladder scan is a simple but really important tool to quickly check for urinary retention in a patient who says they're having trouble emptying.
Quick and easy.
Yeah. And if malignancy is suspected, based on the history or initial imaging, more extensive scans like CT taps or maybe even PT scans might be required down the line. Urodynamic studies are also mentioned as potentially useful after surgery to assess bladder function recovery.
Right.
But the key takeaway from this whole section is that the diagnosis hinges on integrating the patient's history, those clinical exam findings we talked about, and that emergency imaging, primarily the MRI.
Okay, diagnosis confirmed. Cauda Equina syndrome is happening. Your material is completely unequivocal here. This is a neurological emergency. It requires immediate action.
No messing around.
And the definitive treatment highlighted is urgent decompressive surgery, basically to take the pressure off those nerves as quickly as possible.
Prompt surgical decompression is absolutely the cornerstone of management, and the timing is just so critical for preventing permanent damage. You know, management isn't just surgery.
Right, there's more to it.
The notes outline crucial supportive care as well. This includes effective pain management, starting physiotherapy as early as realistically possible to maintain function and help recovery, and establishing strategies for managing those difficult bowel and bladder issues that might involve things like catheterization or planned bowel regimens.
Okay.
They also detail specific treatments that target the underlying cause. So high-dose corticosteroids are indicated if inflammation or malignancy is the culprit behind the compression.
Right.
And intravenous antibiotics are obviously essential if there's a spinal infection like an epidural abscess.
Got it.
Adjunctive measures are mentioned too, things like using PPIs to protect the stomach and bisphosphonates for bone protection when giving high-dose steroids.
Yeah.
Or starting thromboprophylaxis, blood thinners because the patient might have reduced mobility.
Sensible precautions.
And of course, if trauma is the cause, spinal immobilization is also a crucial initial step. This whole phase is really about acting fast and comprehensively addressing the immediate problem and its underlying cause.
Okay. So what about the care after that initial emergency phase? What non-surgical or long-term management is often required?
Good question.
Your notes cover the ongoing needs quite well. Rehabilitation seems critical for recovering any neurological deficits, involving both physiotherapy and occupational therapy to help regain strength and function.
Absolutely. Rehab is key.
For patients who unfortunately have persistent severe deficits, long-term nursing care might even be necessary.
Sadly, yes.
Ongoing bladder and bowel management is essential, which could mean things like self-catheterization long-term, maybe indwelling catheters or using continence aids. And if a tumor was involved, radiotherapy might be needed after surgery. And depending on the underlying cause, other specific treatments might need to continue, like anti-inflammatory agents or chemotherapy or radiation therapy.
Yeah, ultimately, the long-term management is all about addressing the consequences of whatever nerve damage occurred and continuing to treat the original cause if needed. Your material reiterates the absolute importance of that initial urgent surgical decompression in setting the stage for potential recovery.
Right, it all comes back to that speed initially.
It really does.
Yeah.
It also includes a practical little note about addressing lifestyle factors post-surgery, like weight management in cases of obesity, as this can impact overall spinal health.
Good point. Okay, let's look at the outcome then, the prognosis and potential complications. What can a patient generally expect after experiencing CES?
Well, the notes indicate the outlook really depends on several key factors.
Okay.
The underlying cause makes a difference. Critically, how quickly treatment was initiated, there's that theme again, and also the extent of nerve damage that was present before the decompression happened.
Right.
The good news, relatively speaking, is that prompt surgery is associated with a better chance of neurological recovery and fewer long-term complications.
That's something.
However, and this is a tough but necessary point to make, some individuals unfortunately do experience persistent deficits despite timely intervention.
Okay.
The notes list potential residual issues including ongoing motor weakness, persistent sensory loss, and unfortunately chronic bowel, bladder, and sexual dysfunction. These can be life-altering.
Yeah, absolutely.
The potential complications stemming from this include things like chronic pain, significant functional limitations that impact daily life, and understandably, a reduced quality of life. Ongoing monitoring and follow-up care are vital to manage these potential long-term issues.
And speaking of complications, your material is crystal clear on the biggest factor influencing them. It's delayed diagnosis and management.
It's a recurring warning.
The longer that compression lasts, the higher the likelihood and the severity of complications. Those residual issues we just mentioned, the paralysis, sensory abnormalities, bladder, bowel, sexual dysfunction, they are the direct result of irreversible nerve damage that can occur if action isn't taken quickly enough.
Yeah, this whole deep dive into Cauda Equina syndrome, based on your notes, it truly hammers home the critical importance of recognizing those specific red flags really quickly.
Exactly. So what does this all mean for you as you prepare or practice out there? This deep dive, based on your revision notes, really underscores the high-stakes nature of this rare condition. Think about the profound potential long-term impact on a person's independence, their dignity, their quality of life, if this diagnosis is missed or delayed.
It's huge.
It really highlights the immense responsibility that comes with being able to identify this medical emergency quickly and accurately.
Absolutely. We hope this deep dive into your material has been incredibly helpful for your revision. Mastering those key clinical features and really understanding the urgency of diagnosis and treatment are just paramount.
Definitely. And if you are honing your knowledge for exams like the MSRA, remember you can find more detailed resources and, crucially, practice questions specifically designed for your preparation.
Available over at pastthemsra.com.
And don't forget to check out freemsra.com as well. There are free resources there to support your studies too.
Great resources on both.
Keep diving deep into your learning.